You're all a very good audience. I like that everyone suddenly became silent. Welcome everyone to the 2022 Astor Lecture in Medical Humanities. My name is Erica Charters. I'm Professor of the Global History of Medicine at Oxford. I'm also the academic lead for Medical Humanities. Medical Humanities here at Oxford encompasses more than 20 departments and centers that examine the relationship between health and society and that situate medicine within its political, social, historical, ethical, and cultural contexts. And so I'm delighted that tonight's lecture brings together a number of centers here. And so I'm grateful, of course, to the Astor Fund for making these events possible, but I'm also grateful to the Wellcome Center for Ethics and Humanities, the Pandemic Science Institute, to the Oxford Research Center for Humanities, otherwise known as TORCH. I'm also grateful to the Yukiro Center for Practical Ethics, to the Center for the History of Science, Medicine, and Technology, and to ETHOX, which is part of Oxford Population Health. As many of you will know, tonight's lecture is the first of 3 Astor events in the Medical Humanities. So I hope that many of you will also join us tomorrow at 11 a.m. at the Big Data Institute for coffee and pastries, but also for an interdisciplinary roundtable discussion following on from Professor Gostin's lecture, in which he'll also be joined by Imogen Gould, Professor of Law, Michael Parker, Professor of Bioethics, Mark Harrison, Professor of the History of Medicine, and Peter Horby, Professor of Emerging Infections and Global Health, and chaired by Alberto Giugolini, who's coming to us from the Yukiro Center for Practical Ethics. And on Wednesday, we have just a few spaces left for our lunchtime workshop, which is aimed at doctoral students and early career researchers. The workshop will be on medical humanities expertise in global health emergencies, and this will again be run by Professor Gostin. Medical humanities is necessarily an interdisciplinary approach to researching health, medicine, and disease, but very much as these phenomena occur in society. Most fundamentally, medical humanities understands health and medicine as bound up with the human. In this endeavor, Professor Larry Gostin has long dedicated his research and his career to these issues, and particularly to the thorny but fundamental relationships among individuals, society, and health. And so it is truly a pleasure to be hosting him as a University of Oxford Astor visiting lecturer to discuss these topics. Lawrence Gostin is University Professor at Georgetown University, where he is also the Linda D. and Timothy J. O'Neill Professor of Global Health and the Faculty Director of the O'Neill Institute for National and Global Health Law. Alongside, he's also Director of the WHO Collaborating Center on Public Health Law and Human Rights. He began, though, perhaps a long time ago, with an undergraduate degree in psychology before obtaining a law degree from Duke University. In 1974, Professor Gostin came to the University of Oxford on a Fulbright scholarship to study mental health, and he stayed on in England for many years, first as legal advisor to Mind, where he worked to place patients' rights at the center of the 1983 Mental Health Act. He then became General Secretary of Britain's National Council of Civil Liberties, which is now called Liberty, during the tumultuous period of the early 1980s. Professor Gostin then returned to America, where he taught law at Harvard University during the early years of the AIDS epidemic. And this is when he moved his focus to global public health more broadly. Among his many accomplishments, Professor Gostin is known for his drafting of the America's Model Emergency Health Powers Act in 2002 in the wake of the US anthrax attacks. He's also known for his argument for what is often called the sin tax on sugary drinks. But also he's known, and I think most importantly, he's known for his long-standing campaign for a framework convention on global health, grounded in the right to health and aiming for global health equity. Alongside his impressive policy work, Professor Gostin has shaped the fields of public health, global health, law, and ethics through his many publications. I can't even begin to list any of these here. There's so many of them, but I do want to highlight his public health law, Power, Duty, and Restraint, which was first published in 2000, but since reissued multiple times, and which provided the first systematic definition and theory of public health law. Likewise, his 2014 book, Global Health Law, not only defined the burgeoning field of global health law, but also reframed its concerns to move beyond individual diseases and to encompass the conditions for healthy lives. Most recently, in 2021, he published Global Health Security, A Blueprint for the Future. This is a book that he began working on before COVID, which built on his experience in public policy and law throughout AIDS, SARS, Ebola, MERS, and Zika. But it also includes his experience during COVID in working with the WHO, with the World Bank, and Gavi, just to name a few of his institutions. And just published last week in the Journal of American Medical Association is his overview of what it means to be living in an age of pandemics, from COVID-19 to monkeypox, polio, if not the next disease X. I can therefore think of no better individual to give this year's University of Oxford Astor Lecture in the Medical Humanities than Professor Lawrence Gostin, entitled Global Health Emergencies, from Ebola and COVID-19 to monkeypox and polio. Professor Gostin. Mike, sorry. The Zoom is on there, so I think we need to leave it on. We're live streaming it in case anyone happens to figure it out.
She's Canadian and I'm American, so it's bound to happen.
We'll see how the technology is doing. We're still on.
Okay,
it's all good.
still on.
Perfect.
Okay, good.
Sorry.
Sounds great. Well, thank you, Erica. That was really lovely. If I don't know, half true, but lovely. And thank you for all coming. I think half the audience or my family or friends. I promised my wife, Jean, who I met at Mind, that I wouldn't mention her, but I have. Sitting next to them is Cynthia and David, who we've known, what, 70 years? So, and we've got a multitude of friends. Thank you for coming on this side of the room. I'm going to talk about pandemics. We've just been living through it, and I'm just going to have some. Oh, I've got some friends on that side too. So I'm just going to talk a little bit about how we got here, what we've done wrong, and how we can fix it. And so the Global Health Security book that Erica was kind enough to mention talks about a blueprint for reform, and I'll try to give you some of the highlights of that. I think it's no secret that COVID-19 changed every life on the planet in fundamental ways. It's been a horrific experience, although, sorry, Jean, my wife says I've got the pandemic I always dreamed of, but I don't necessarily want this pandemic. It's been hard on everyone. But it is really the first major pandemic that we've suffered through in our lifetimes since the great influenza pandemic of 1918. We thought we would never experience that kind of a pandemic again, simply because of the miracles of science. We've got vaccines, therapeutics, diagnostics. And in fact, with COVID-19, we were remarkably quick off the science. We did everything else wrong. In the UK, the US, throughout Europe, most of the world. But we got the science right. The first time that we've gotten the vaccine this quickly. Normally it takes about 10 years on average, a little more, to develop a vaccine. For some, we never have, like for HIV/AIDS. For others, we still haven't really deployed, like for Ebola, and it's taken decades. And the very quickest one we've ever had is from laboratory to marketing was mumps, which was 4 years. And we had an effective vaccine in 1 year. There were, of course, the more traditional vaccines like AstraZeneca and Novavax. But the most revolutionary, and the one that you're all getting now, or at least for the older population, is a new bivalent messenger RNA vaccine. By the way, in the UK, you were duped a little bit because Moderna vaccine is giving you the bivalent of the original Wuhan virus plus the original Omicron variant. Whereas in other parts of the world, Germany, the United States, and others, they're selling the BA4, BA5 subvariant that Americans are getting. But nonetheless, the point is that even with this vaccine, which initially was 94 to 95% effective against transmission, has been a lifesaver. It turns out that it doesn't really prevent infection, which is very disappointing. We've seen lots of breakthrough infections, lots of reinfections with different variants, and even with the same variant. This SARS-CoV-2 is the most wily virus I've ever seen. It mutates quickly. It has immune escape capabilities. But nonetheless, it really is highly effective against hospitalization and death, particularly for the most vulnerable populations among us. But even with that science, we're still suffering through it, despite my president, Biden, who I think is terrific, actually, saying that the pandemic is over. I don't think it is over yet, and certainly not in most of the world, but even still, even in the high-income countries. But we've been through outbreak after epidemic after pandemic for quite some time now. In our modern lifetimes, of course, it began with that vivid image that only people of kind of a certain generation will remember, of a child in an iron lung. The fear and trepidation caused by polio was absolutely enormous. And then, of course, the more modern outbreaks and epidemics, Ebola in West Africa, which was a salutary lesson, and then again in the Democratic Republic of Congo and the DRC. We've seen it with H1N1 pandemic influenza that circulated the globe in a matter of months. We've seen it with a series of coronaviruses now, from Zika to SARS-1, to MERS, and now SARS-CoV-2, and then Monkeypox, of course, which remarkably, we didn't seem to have learned any of the lessons that we thought we had learned with COVID-19. All of the same mistakes we made right off the mark, from the problem of scarcity of vaccines and therapeutics, with this time the United States being singularly responsible for that, because we had in our strategic national stockpile virtually all of the pox vaccine that was available on Earth, whereas with SARS-CoV-2, of course, that was mostly Europe and the United States and Japan that had hoarded those vaccines. We also didn't deploy them quickly enough, nor did we deploy therapeutics. We were very awkward, again, with our health communication, particularly towards communities most at risk, men who have sex with men. And then most recently, we thought that we were on the verge of eradicating polio. Just this afternoon, for Mick Borick's Rotary Club here in Oxford, I gave a talk about what the Rotary Club's major investment over many, many years, along with the Gates Foundation, the Gavi Alliance, and WHO, which is the polio eradication initiative. And that was literally just stubborn strongholds of polio, of little clusters, principally in places of deep conflict and lack of development: Afghanistan, Pakistan, Somalia, places like that. And now I actually underestimated this morning when I said it was in 30 countries, about in 35 countries. Here we are kind of did learn in some ways from COVID-19, because it's probable that we never would have known we have had these multiple outbreaks of polio had it not been for two innovations during COVID-19, both on surveillance. One, of course, was genomic surveillance, where we were able to pick up, particularly in places like South Africa, which picked up the surveillance through its surveillance of the original Omicron variant. Of course, South Africa was punished for its good citizenship by targeted travel restrictions, both in the UK and the US and in Europe. But we have much greater capacities for genomic surveillance of viral mutations now. The second, of course, was that we've done more active surveillance through wastewater. So how did we find out that polio was circulating in London and New York? Through COVID wastewater surveillance, which promises to be another big breakthrough. Nonetheless, it's truly disheartening to see it spread so widely. You might ask why it's spreading widely, particularly in places like the United States and the UK, which use the Salk inactivated vaccine. An inactivated vaccine, of course, doesn't cause disease. It can't, because it's a dead virus. But in most of the world, and this was a great innovation in polio eradication, we saw that the very attenuated virus, or live virus, which was most effective, the Sabin vaccine, was able to really extend our reach of polio vaccination around the world. But in 1 in 100,000 cases, that inactivated virus, that weakened virus can mutate and become pathogenic and then spread. And travel-associated cases came to the UK, US, now 35 countries around the world, and that they spread to unvaccinated populations. So we've only eradicated one disease, smallpox, and we were on the verge of eradicating another, polio. But those two are susceptible to eradication, meaning that they're wiped off the face of the earth because there's no animal reservoir. And that I'm going to connect that animal reservoir to zoonoses in a minute. So I wanted to get this grounding. We will never eradicate all of the diseases I've talked about, or in fact, any of the diseases except polio that I've talked about, because they are all of animal reservoir. So you have wild jungle meat that is presumably keeps outbreaking itself in Africa, particularly West Africa. We see coronaviruses in bats and other species. And so it's going to be impossible to eradicate them. But with vaccination, we should be able to eliminate. People confuse those two terms, which just means that we bring the disease to a minimal or negligible level in a given geographic area. So we were able to do that, for example, with most preventable childhood vaccine diseases like measles. But false information, vaccine hesitancy, the disingenuous link between autism and measles means that they've reappeared in places like the UK and the US, which at times have lost their elimination status, which shows the importance of vaccination, which CDC called the greatest public health achievement of the 20th century, and no question that it still is. And so between polio, Ebola, H1N1, and other influenzas, swine and bird flu, which is circulating in East England right now, coronaviruses, SARS, MERS, SARS-CoV-2, monkeypox, and what WHO calls disease X. which is that unknown disease that will probably jump from an animal species to a human species and devastate the planet. Now, it may appear to you, just from a human experience, that we're experiencing more frequently these kinds of health crises. I can't personally remember, and you might not remember, all of the lists of diseases, and I don't think I even mentioned Zika, in just near memory. And if that seems to be an intuitive sense for you, it actually turns out to be true. We've had a threefold increase in outbreaks of novel or re-emerging infections. And the question is why? And the answers are a little complicated, but very, very clear. One reason, of course, is zoonotic spillovers. This is when an animal transmits a virus or other pathogen to a human, and then you get sustained human-to-human transmission. Now, most of the time, we don't even know about these. They happen every day. Most of the time, we don't know because a human might get them, a farmer might get it, but it has very inefficient human-to-human transmission. But sometimes, either through chance or mutation, you get that sustained human-to-human transmission, which we saw, for example, in the original SARS outbreak, and we saw it so clearly with COVID-19. I remember very, very vividly, and Jean was in the room with me when we had around December of 2019, about mid to early December, before anybody knew about it. On my social media, I use WeChat, which is a Chinese version of WhatsApp. It's actually a better version, except the problem is you don't want China to know what you're doing, and if you use that, they absolutely do. So we had over a neighbor who happens to be a very prominent, highly respected and visible television reporter in the United States. And we were serving him tea and biscuits. And I said, you know, Tom, I'm hearing about this mysterious virus in Wuhan, and it's a SARS-like coronavirus, I think. I'm really, really worried about it. You probably should know about it. And he said, pass the biscuits. He could have had a Pulitzer Prize, but instead he preferred the biscuits because nobody thought that these things could happen, but of course it did. It was enormously consequential. We saw social media explode, and then finally, it wasn't until early 2020 when China was very, very late in reporting what was obviously a human spread of a SARS-like novel pneumonia. WHO didn't report it until early December. And even then, it repeated what China was telling it is that there was no efficient human-to-human transmission. All of us knew, at least I certainly did, most of my friends did, that this was absolutely untrue, because once you see clusters in healthcare facilities among physicians, and when you see lots of spread out of a particular animal market, like the Wuhan market, you know that you're experiencing an outbreak. And of course, it then spread like wildfire. We almost don't remember how it went from Wuhan to Greater Hubei province, through to mainland China. It swept through East Asia to Europe and then to the Americas. And while all of this was happening, Europe was asleep watching it happen in Asia. America was asleep watching it happen in Europe. But you remember people on balconies, you know, cheering health workers and ringing their bells. And that was the beginning of something that I never expected to see in my lifetime. You know, after the 9/11 attacks, the CDC asked me to draft the Model Health Emergency Powers Act, which Eric mentioned. And I foresaw most of the kinds of problems that we ended up seeing. But in my wildest imagination, I could never imagine a city like Beijing or Delhi or Rome or London or New York completely closing down. I mean, it just gives me chills and tears to even think about what we've been through. And the question is, have we learned the lesson? So how did COVID begin? I mean, there's a big controversy, and in fact, WHO was caught in the middle of a huge geopolitical struggle between the two great superpowers, with the United States under Trump, God help us, announcing what I would have thought was at once unthinkable. You know, if you think of Eleanor Roosevelt and all she did for the UN, all the United States did to form the UN, the Universal Declaration of Human Rights, and WHO as the first international specialized agency of the United Nations, understanding how crucial health was to peace and security in the world. And nonetheless, what happened was the United States president did something that I wrote in the New York Times as saying the most ruinous decision of any president in American history. He announced US withdrawal from the World Health Organization. Of course, Biden on day one in office, it was his very first executive order, and I was in touch with the White House and urging them to do it, reverse that. And so we never did withdraw, but it gave you a sense of where we were. So that virus, there was a dispute over whether it was at the Wuhan Institute of Virology or out of the Wuhan wet market. I think it's pretty clear to most in global health, but not all, but most, that this was a natural zoonosis from a bat in southern China, which harbored that. Bats are incredible. They can absolutely hold hundreds of viruses or other pathogens and not get sick. And so Cynthia's granddaughter yesterday said, well, why don't we find out why and use the bat genome to actually prevent these kinds of viruses? That was a really good idea coming from the mouth of babes. So what's causing all these pandemics and epidemics and outbreaks? First is the idea that humans are encroaching on our ecosystems. They're changing wildlife environments at an alarming rate in agriculture, natural resource extraction, urban expansion. Ecosystems are destroyed, wild species are displaced, they're placed under stress, and they come into contact with humans. So things like land management and deforestation in Brazil, or other ways that we catastrophically change our relationship with animals. This is so-called One Health in my field, has an enormous impact on these things. Human-caused climate change is dramatically increases cross-species viral transmission because global warming makes some habitats less habitable. Species harboring pathogens migrate to cooler latitudes, potentially across continents. Bats, which I've talked about, can travel very long distances, as can bird flocks carrying avian influenza. And climate change expands pathogen vectors to new geographic areas, for example, propelling mosquito-borne illnesses. It turns out that the greatest killer of humanity are not humans, which you would think through our wars. Humans are second, mosquitoes are first. Think malaria, dengue, Zika, chikungunya, a whole range of other areas. Urbanization is also a problem because as people get closer together, they can transmit infections more. The World Bank estimates that close to 60% of the world's population, which is more than 4.4 billion people who are living in cities now, 70% of our global population will live in urban areas by 2020. With that, we also have the combination of conflict and wars. We see it in Ethiopia, Somalia, Ukraine, where we've got mass migrations of an unprecedented nature. In 2020, nearly 4% of the global population was forced to migrate, either from climate migration, conflict, hunger, food insecurity. So, what are the lessons that we should be learning but really haven't? Some of them are pretty clear. Weak health systems. Health systems, COVID shows that health systems were weak everywhere. It turns out that the international health regulations, which actually govern pandemic preparedness and response, it's an international treaty, requires countries to meet what they call core health system capacities, things like human resources, the ability to respond, laboratory capacity, surveillance capacity, and even by WHO's own assessment, almost no country was able to fully comply with their treaty obligations under the international health regulations. But it's really interesting that the Global Health Security Agenda, which I'm on the board of, it's basically a global assessment, an independent, high-level global assessment of health system capacities, which is run out of the United States, CDC, Johns Hopkins, and The Economist from here in London, ranked the United States first in health system capacity, UK second. And we were probably among the two worst performers in the world. That probably had to do with leadership, but it also had to do with we don't have as good health capacity as we thought we did. Global cooperation absolutely shattered during COVID-19, if it had ever existed. Mutual solidarity, global and mutual responsibilities, what we call shared and differentiated responsibilities among nations. That's a concept from climate change, absolutely was shattered. Every country reverted to itself, particularly the high-income countries. We performed badly ourselves. We hoarded vaccines and therapeutics. Our populations distrusted us. And it turned out that one of the greatest predictors of pandemic response failure was lack of trust in the population in its government, and particularly in its science and public health. And it just turned out, whether it's because of Boris Johnson or Donald Trump, or just because the way our countries are, that both of our countries just don't trust the government. We have good reason not to. But it also spilled over to distrust of science and public health agencies themselves. And so we performed rather badly. Countries that had high trust, like Japan, Taiwan, Singapore, did relatively well during the pandemic. And then there were other countries that were just sui generis, like New Zealand and Australia, which are really island nations. They actually fared fairly well during the great influenza pandemic, and for that reason did here too. We can talk a little bit about the story of travel restrictions in question and answer, but I don't want to dwell on that right now. So health systems, global cooperation was a lesson, and of course, equity. Before COVID, I always thought that if you were to talk about one singular global narrative, one story that most people in the world would understand, it was the idea of the haves and the have-nots. The top 1%, the top 10% with the rest left behind. The UN Sustainable Development Goals talk about, no person left behind, but everyone felt left behind. There was job insecurity, income insecurity, health insecurity, deep inequities. And I've always been inspired by Martin Luther King's statement. He said that all inequalities are unjust, including racial inequalities. But he said the most pernicious inequality are health disparities, health inequalities. And I thought that was really wise because, what did your mother tell you? If you've got your health, you've got everything. Right. And so it's really important. Health is just essential to our well-being and our security, both physical and mental. Equity just plummeted. Yes, it's true that our countries, and particularly the United States, but also many of the high-income countries, including the UK, for the first time in living memory, actually lost life expectancy. Life expectancy in the US during COVID lowered by over 2 years. And it was 4 years for African Americans, 5 years for Indigenous Americans, Indian Americans. Just a shocking loss of a good life. Now, there are lots of reasons for this. Some of it has just to do with compounding inequalities. People who were most vulnerable were frontline workers. They had to go to work. They also tended to have the highest rate of chronic diseases and therefore vulnerabilities. We saw nursing homes and other vulnerable populations absolutely devastated. But besides compounded inequalities that were already existing, there was just this idea that the rich got access to all of the vaccines, all of the therapeutics. It happened from the original vaccines through to the bivalents now, through to monoclonal antibodies, diagnostics, even personal protective equipment, and now with the most advanced therapeutics, particularly the antiviral Paxlovid, which is very effective in vulnerable populations against hospitalization and death. And so the vaccination rates in sub-Saharan Africa were, even now, only 25%. Health workers are not fully vaccinated there. In fact, they're around the 1/4 level, while we have very high levels of vaccination around the world. It turns out the UK and the US are very proud of ourselves and our vaccination rate. We're actually not that good, but we're better than others. So we've been plagued by not necessarily a lack of supply, but misinformation and disinformation. Which leads me to health communication and trust. Another lesson was just trust in public health agencies plummeted during COVID-19. As somebody who's kind of worked in public health my whole life, and if Jean's joke was true that I've got the pandemic I always wished for, what I would have wished for is for people to value science, medicine, public health, and all of the good that can come of a healthy population. But instead of the pandemic advancing the common good, it advanced the me. what's in it for me? What's in it for my country? And we were very, very selfish for others. We distrusted our public health agencies. We vilified them in many cases, including public health officials, like my good friend in the United States, Tony Fauci. And Tony's made a lot of mistakes. I've made a lot of mistakes, but nobody can ever doubt the sincerity and the decency of that man. And yet, he needs a 24-hour bodyguard protection now. And that's true with a lot of my friends. So health communication plummeted. We saw that with COVID. We saw it with monkeypox, with really terrible messaging around particularly MSN communities. And it's really sad to see this kind of deterioration. So instead of asking what I can do as an individual or what I can do as a country to help my community, my state, my province, my country, my nation, my world, we revert to selfishness. I've never quite understood that. We always ask what my rights are and not what my responsibilities are. And our political leaders are doing the same thing. Part and parcel to this problem of health communication is that virtually all health indicators have plummeted during COVID. Everything from reverses in reductions on absolute and deep poverty to insecurity and any of the other the sustainable development goals. Most notably is the reduction in childhood vaccinations all over the world. If you think things are bad here in the United States, you should look at places like Mozambique and other countries where their childhood vaccination rates have indeed plummeted. We need to do a lot more with preparedness. Things like the Global Virome Project could identify high-risk pathogens that spill over, thereby informing the development of therapeutics and diagnostics. We need better and more robust response systems. And so I want to end with a little bit of a discussion about what we're doing now, what's at stake. And we have a crossroad now, like we've never had before. I used to say that there was the great generation. We've never ever had an opportunity like the great generation had after the ruins of World War II and the formation of the UN. So within just a couple of years, we developed the United Nations. We ratified a constitution of the World Health Organization that said that the right to health was the most fundamental right of all human beings. We had the Universal Declaration of Human Rights and the wonderful Eleanor Roosevelt's role in that. If you ever go to Washington, we have some lovely museums, but one of the most neglected ones is the FDR Museum with quotes from Eleanor and Franklin Roosevelt, things that no politician would say today. Not an Obama, not a Biden, no one. Really, truly inspiring. And so those were golden years. So in the aftermath of the pandemic, when it is over, and one day it'll become endemic, but we're in a long, hard slog with COVID. We'll never eliminate it, probably not in my lifetime. The best we can hope for is to get to somewhere around the background level of influenza, which is a really big killer. And that won't be for many, many years to come. So we're at a crossroad. I posited in my book, the thesis of that book is that we lurch from panic to neglect, panic to complacency. And the question is whether or not in the aftermath of COVID, we will return to complacency. There are a lot of signs that that's already happening. A lot of signs. None of us are wearing masks, for example. But there are some hopeful signs, and I think this could be a truly transformational moment for global public health, Erica, I really do. And the reason is that we have three remarkable processes ongoing, processes that most of you, even the most sophisticated, smartest people in the world sitting right here, may not even know about, but they've happened. The first one is WHO financial sustainability. It may surprise you that the annual global budget of the World Health Organization is considerably less than the budget of a large US teaching hospital or one in the UK for a global responsibility. That's truly shocking. What's worse than that is that the World Health Organization actually has control, and I should say that of that large, very tiny, minuscule budget of WHO, a huge chunk goes to eradication of a disease, which only really has, handfuls of cases, polio eradication, with almost nothing for injuries, which are devastating, mental health, non-communicable diseases, cancer, heart disease, diabetes, asthma, other respiratory diseases, shockingly little. I mean, for all the years I've known and worked with WHO, and I've worked with them awfully closely, and I've been to Geneva too many times than I care to mention. I've never known them having more than 2 people devoted to mental health globally. Just to give you one example. So apart from the shockingly low funding rate, WHO only has control of about 18% of its budget. All the rest is controlled by the Gates Foundation, the UK, the US, and the European Union, most of it, some from Japan. That earmarks its funds to its most favorite project. And so the Gates Foundation has a greater impact on the global health agenda than WHO does, just to give you an example. And so one thing that we needed to do is have more robust and sustainable WHO funding. I've worked with a German MP named Bjorn Kummel, who is the head of the WHO Sustainability Task Force. And we used to talk, once a week for a long, long time. I'm meeting in Berlin soon. And, he would say, Larry, I'll never get this through. He was the head of the task force for it. I'd never get it through. At the executive board, just this past executive board, it failed. Countries said, no, we're not going to give any more to WHO and no mandatory assessments. Remarkably, it turned around. And actually, I give Biden credit for that. The US withdrew its opposition to it, and it passed the last World Health Assembly last May. And so we now have at least a pathway toward more sustainable funding. But the two most transformational things are, one is reform of the international health regulations, which I talked about before, which is the global treaty that regulates pandemic prevention and response. I have to give a note of conflict of interest because I'm the vice chair of the WHO reform committee for the international health regulations. And so I am biased. I have to be careful what I say. But nonetheless, the opportunity for historic reforms of a treaty that performed so terribly badly during COVID-19 is really inspirational. It was last changed after SARS, but it needs far more fundamental reform. And I hope countries negotiating the reform will eventually agree to a major new reform. The other is colloquially called the Pandemic Treaty. This is a brand new treaty called the Pandemic Treaty. It was originated by a call from 70 heads of government, including the European Union and international organizations like the Director General, Tedros, at WHO, calling for a new treaty. It's had a lot of pushback from the United States, Brazil, India, China, Russia, all of the major powers. But at the last Health Assembly, the Assembly developed an international negotiating body for the treaty, which is now ongoing. So the treaty basically is supposed to cover 4 things: prevention, preparedness, response, and recovery. I've talked a lot about all 4 of those things, not so much about recovery, but it looks very much like we're going to get to the finish line by May 2024 on preparedness and response. I think there's a lot of support for that. Now, it still remains to be seen how robust those 2 things will be, and it remains to be seen how many countries will sign on. But one of the things we've been doing at WHO that I think is incredibly innovative, if we can pull it off, is to link the international health regulations with the Pandemic Treaty, with a new annex to the international health regulations. Legally, this is really intriguing because there are lots of countries around the world, like the United States, that could never ratify a new treaty. And truly, there's not a lot of global appetite for this kind of thing. You saw how well Bolsonaro polled in the Brazilian vote yesterday. And so we have to find a way to actually get the Pandemic Treaty norms into something that countries can abide by. The international health regulations is already ratified by 196 countries around the world. It's perhaps the most ratified treaty in the world. And by putting an annex on that refers back to the Pandemic Treaty, countries, even if they don't abide by one, have to cross-reference from the other. If we can pull it off, it might pull countries that are reticent, but big, important countries like the United States, Brazil, India, China, Russia, and the UK, frankly, who may not ratify a pandemic treaty into that treaty. And we hope that equity is going to be a really important part of it. In fact, the international negotiating body is having 4 what they're calling international focus groups that looking at the 4 major parts of the treaty. We just had one on law, which I participated in. I'm going to participate in this next one, which is on equity models. How can you devise a system that embeds equity? It's hard because you'll remember the ACT Accelerator and COVAX were designed mechanisms specifically for equity, but they failed. So we've got a lot of innovative things that we can do, and we can pull other countries in. So I think on things like preparedness and response, and through this innovative way of linking the 2 treaties, which to my knowledge has never happened before, we might be able to really have something truly transformational. But what you'll notice is that I left out prevention and I left out recovery, because those are going to be really, really heavy lifts. I think it was about 2 weeks ago I came back from Geneva, and part of my discussion, part of it was with WHO to talk about this innovative link that I mentioned. But the other part was a series of countries like Australia hosted a meeting of about 80 government representatives on the pandemic treaty under the banner of One Health. And I was supposed to talk to these country representatives and get them to understand what I've been telling you about the importance of climate change, sustainable agriculture, land management. In other words, we need three things. We need healthy people, we need healthy animals, and we need a healthy environment. Now, the way I put it to these government heads, they couldn't disagree. I said, not one of you can say that this is an absolutely crucial for the future of humankind. It's impossible to deny. They all agreed. But yet almost none of them, except for some countries in Africa, which were still not sure, were prepared to embrace One Health in the pandemic treaty. And so we have to find innovative ways of trying to get zoonotic spillovers and other kinds of climate change and land management commitments and human rights commitments into the pandemic treaty. We have ideas that we've talked about, and I can talk, but I'll wait for question and answer about how we can do that. I do think there's a pathway. It'll never happen by May 2024, but I think it still can happen, and I can explain why. The other thing that won't be decided by May 2024, and I actually can't even think of a pathway how we can make that happen, is recovery. That is equitable recovery. That is every country in the world. I mean, look at the pound right now. And that's not just Brexit, that's also recovery from COVID and a whole range of other things. And in the United States, every country in the world is having an awfully hard time recovering. And to find more resilience in our societies, and I'm talking about economic resilience, but I'm not just talking about that. I'm talking about resilience in education. We've had huge education gaps with schools closed. We've had huge problems with race and gender and a whole range of things that have really upended our society. We need resilience to recover from this. And the pandemic treaty could help us do that. But there's little appetite for those two big things, prevention, and everybody knows prevention's better than cure and cheaper than cure, and recovery. And everybody knows that planning for recovery is better than an ad hoc, individualistic, nationalistic response. Yet we'll do very, very little. And so I'll just literally end this way. We're at a turning point in our global society. We can either go back to our comfortable complacency and wait for, as Camus said, for the next plague to rain down on our head and wonder why or how it happened, or we can prepare. And that's our choice. And so when disease X strikes, the question is, will the world be ready? Or will we just simply fail? And I have to say that at this moment, despite the historic opportunities we have, that huge question hangs in the balance. Thanks.
Professor Gostin, for such a wide-ranging lecture. We do have a little bit of time for questions. I should warn the sad people online, it's lovely to have you there, many of you there. We can't take questions from you, but this is the bonus for coming in person. So we do have a little bit of time to take questions from people in the room. And I wondered if I could start with a very general question about the role of law and global health law in your outlook, because one of the things I was struck by, which resonates with me as a historian of epidemics, is the dissolution of trust in institutions and public health more broadly. And I just wondered, because in your framework, we seem to have a case in which law might lead in restoring that trust. And I wondered, when it comes especially to the case of not only public health law, but also global health law, how that process works, what the relationship is in terms of rebuilding trust, and then also enacting these international legal frameworks.
Yeah, I mean, Erica, you've touched on perhaps the most important issue facing us, is how we restore trust. And we've got, we've got an article coming out in a global coalition. I'm one of the authors of many on exactly on that issue, not the legal side, but basically about the plummeting trust and how we restore it in the journal Nature. It'll be out in a few weeks, and we've got a project that's trying to think about how we can restore it. It's really hard because law can be a solution, but it turned out that law, I don't know whether it was the problem or not, but people just didn't like to be told by law, by policy, mask up, roll up your sleeve and get a vaccination. So all of these kind of public health laws that have existed for centuries and have been upheld by courts everywhere are suddenly under attack. Just today is the very first day of the 2023 Supreme Court term. And if you know anything about last term, we're in for a real rough ride, and they're dealing with lots of trust issues, voting rights, race and affirmative action, and a whole range of other things. So law can be a solution to it, but it can also be a cause of it. Other people talk about, well, what can you do about social media and disinformation and misinformation? How do you deal with that when you've got in the US, the First Amendment, and other liberal countries around the world, progressive democracies, the idea of freedom of speech and freedom of expression? How do you strike that balance? I wish I knew the way to get the public to understand how important it is for themselves and for their families and their communities to have some trust in science. But it's going in the wrong direction. And I really don't know exactly how you begin to do it. Part of it was an own goal. I mean, public health, law, everything else. We were really, really bad at health communication. You'll remember throughout the pandemic, from WHO, from Public Health England, from CDC, do masks work? Yes, no, no, yes. What kind of masks? Surgical masks? Yes, no. KN95? Yes, no. Do masks prevent transmission to others, or does it actually protect you? Yes, no, yes, no. And on and on. Is it an aerosolized spread? Absolutely not. Yes, it is. And so we didn't do public health communication 101, which I always say is the following. You tell everybody transparently, this is what we know. This is what we don't know. This is what we're doing to find out what we don't know. And and science will evolve, and we'll tell you as soon as we know, but not to promise that you know everything and then have people think, oh, well, science didn't know anything and you were all stupid. The scientific process is one process, and I'm sure in the humanities, one of the issues is how you deal with uncertainty, in this case, scientific uncertainty. And we had just I call it just an incredibly wily virus that nobody could quite understand. We still don't understand it. Our vaccines don't even prevent transmission. Why? And so there's a lot we still have to learn, but I think one of the fundamental things, and this is something I really want CDC and WHO to do, and all the public health agencies around the world, is really have a multidisciplinary anthropologic understanding of how you communicate important facts to the public.
Questions from the audience?